Good afternoon. Welcome to the Clinical Excellence Program by Department of Health and Family Welfare and Ministry of Health and Family Welfare, Government of India. AIMS Bhubaneswar and SCB have joined hands for a series of webinars updating you on COVID on different topics. And for today, we have a very interesting topic, the fungal infections in COVID-19. You have heard that how the black fungus or the mucormycosis has created havoc all over the country, and we are still trying to save the life of our patients from that. And no sooner the black fungus fear has gone, the white fungus has come. There's nothing but candidiasis and a widespread infection because of immunosuppression. And say it be black, white, yellow, red, or whatever fungus, but many opportunistic infection have the risk of attacking a patient who is post-COVID or who is under very high dose of steroid and poor blood glucose control and other immunocompromising factors. To take that, we have Dr. Manoj Panigrahi, additional professor of pulmonary medicine, AIMS Bhubaneswar today, who will be speaking on fungal infections in COVID-19. And our elite panel, Professor Jyoti Patnaik, Professor Prasenjit Mohanty, Professor Nirupama Chaini, Professor Shubhabrata Parida from ACB, and Dr. Anupam De, Dr. Satyajit Mishra, Dr. Shubrat Behera, Dr. Vajantiwala Mishra, all are there from the AIMS. And Dr. P.R. Mahapatra, our head of pulmonary medicine, AIMS Bhubaneswar, joins me in moderating the program. Without much delay, we invite all of you, and I'm sure the number will go on increasing gradually. And to start the program, we invite our Director Public Health, Dr. Niranjan Mishra. Government of Odisha has formed a mucormycosis committee, and Sir is the convener of the committee, and he coordinates all our meetings, and all our head of skin BD, head of microbiology, head of ophthalmology, Dr. Jyoti Patnaik, myself, we are all members taking into consideration different cases, the reporting and coordination. I'm sure AIMS also has similar structure where they are analyzing their data. So Dr. Mishra will have a beginning of this important session. Following that, we'll listen to Dr. Manoj Panigrahi and take up all your questions related to fungal infection or any part of the COVID at the end of the program. That's why I welcome all of you. I invite Dr. Mishra for an introduction to today's webinar. Dr. Niranjan Mishra, Director Public Health, sir. Dr. Niranjan Mishra joined.
He's there.
Sir, you are not audible. Full team.
Is it audible now?
Yes, sir.
Thanks.
Still the voice needed to be little louder.
Is it clear now?
It's little low voice, sir.
Sound is it okay?
Yeah, it's audible now, sir. We can go ahead.
Thanks, Professor Panda, for inviting me. So happy Doctor's Day to all, particularly in this challenging COVID time. We all know that COVID has opened up new chapters, new areas to work on, and new areas to challenge the doctors community as large. One of such area is mucormycosis. We had not come across these issues in the past wave, rather it came to the notice during this second wave that started after March this year. A large number of cases reported from Maharashtra and Gujarat, and suddenly it took a very aggressive turn to there are thousands in number in Maharashtra, Gujarat, and other states. But we have reported cases here in Odisha too. There are not many hypotheses and discussions. So many aspects why there is such a upsurge now is again matters to be studied. There is a huge galaxy of speakers here who will be talking from all the aspects, from pulmonary to the ENT and dermatology, and we have microbiologists in the panel. They will be discussing all the aspects of mucormycosis, but obviously this is an area to be considered. Why? Because whatever has been told, they are linked to depressed immunity, they are linked to diabetes, they are linked to wider use of steroids. But we all know that diabetes was there, steroid use was there. People are taking quite a long time steroids. But why there is an increased incidence after this second wave? Why it was not there after the first wave? This is an area is to be against, still is to be worked out. I know that a lot of centers are working on this. There must be something that has triggered the mechanism for which there are now increased incidences of mucormycosis coming to the light. And as Professor Panda has told, we have a task force in our state to look at after the issues, and we have made it a notifiable disease, and we maintain a registry of patients who have been getting treated in our state. As on today, we have about 128 cases registered of mucormycosis. Out of them, unfortunately, 18 have died because of various reasons. But obviously, this is going to be watched and to be debated in the fora like this. So thank you all, and we will be watching and listening all our panelists, elected panelists who will be deliberating on various issues of mucormycosis. Thank you. Come to the webinar.
Thank you, sir. Thank you for that nice introduction. And you can see Dr. Mishra working with the full team of IDSP Odisha, and day in and day night, actually morning to night and day in and day out, all team are working just to make life of people comfortable. And we are trying to give the best knowledge, best updated information to all of you, all the doctors of Odisha who are taking care of the COVID patients. And with this, thanking Dr. Mishra, I invite Dr. Manoj Panigrahi to start his presentation, sharing the screen. And I'm sure his contents will be very informative to all of you. Before that, I welcome all our panelists, Professor Patnaik, Professor Mohanty, Professor Choini, and Professor Parida. All are here, and the whole AIMS team are here. And we'll take the questions at the end, and also take the panelist comment at the end. Without much delay, I request Dr. Panigrahi to share screen and start his presentation.
Thank you, sir. Thank you for the introductions, and also I thank Professor Mishra for taking the introductory note, and as well as the giving us a view about what is going on in Odisha now as far as the mucormycosis is concerned, and the number of cases 128 odd plus with some 18 mortality, and they are doing a great job for this surveillance of this disease, and we hope we will conquer this soon in time to come. So I will start now to share my screen. Is it visible now?
Yes, Manoj, it's
Yes.
visible.
Okay. Thank you, everyone. Thank you, participants, and thank you, panelists, all my co-panelists. So today, in next few minutes, we will be discussing about the emerging issues of invasive fungal diseases. It's not only focuses on mucormycosis. No doubt, mucormycosis is one of the things which is quite overt and visible to us, and it has catched the limelight nationwide in view of its disabling and debilitating picture it presents to us once the patient develops, particularly the rhino or cerebral form of the disease. But nevertheless, there are many other fungal diseases which can invade and produces disease manifestations, particularly in patients with COVID-19. So I will just touch upon briefly on this thing, because in-depth discussions will take long time, and that's not the aim of this forum also. This is just to highlight the importance of the emerging issues of invasive fungal diseases among patients with COVID-19. So the brief outline of my presentations will be, we will try to understand the risk factors involved in producing invasive fungal diseases. What are the different sampling techniques that are adopted to confirm or refute the diagnosis of invasive fungal diseases on a broader perspective? The case definitions, this is particularly for aspergillosis. What is the proposed case definition of COVID-19 associated pulmonary aspergillosis or invasive aspergillosis? Then briefly about the epidemiology of COVID-19 associated invasive fungal diseases, whatever we know so far, and in very gist, the principles of management of invasive fungal diseases associated with COVID-19. I think there is some issue with this slide, but nevertheless, I think it is visible. These are the classical risk factors that we all know from our basic understanding from the very beginning, right from our MBBS and MD career, that there are well-known risk factors for invasive fungal diseases. As far as invasive candidiasis are concerned, we know that multifocal colonization, then diabetes mellitus, GI perforation, increasing age, pancreatitis, sepsis, patients on hemodialysis particularly, broad spectrum antibiotic use in the ICU context, central lines, use of corticosteroids or any other form of immunosuppressants, gastrointestinal surgery, and there are certain other surgery, but those are of lesser risk, particularly the left ventricular assist device placement, then long-term stay in the hospital or long-term stay in the intensive care units, mechanical ventilations, total parenteral nutrition. These are well-known risk factors for invasive candidiasis. And if we look into this, many of these factors will come into play when we treat a patient of critically ill COVID-19 patients, because they will remain in ICU for a long time. They may require hemodialysis. We are using steroids. So it's not surprising that people with COVID-19 also developing invasive candidiasis. As far as the invasive aspergillosis is concerned, there is some font issue with this slide in this middle one. So some of the risk factors are missing, but nevertheless, we know many of these risk factors are common to all the three forms of invasive fungal diseases. Like persistent neutropenia is one of the biggest risk factor for invasive aspergillosis, And as far as these risk factors are concerned, these risk factors have particularly been defined in the terms of or in the context of hematological malignancy and stem cell transplantations in this particular group. So these typical risk factors for invasive aspergillosis, like persistent neutropenia for more than 10 days, and here we define neutropenia as absolute neutrophil count of less than 500, or any hematological malignancy, hematopoietic stem cell transplantations, solid organ transplantations, then corticosteroids therapy, particularly more than 15 milligram per day or 20 milligram per day for more than 3 weeks. So these are well-known risk factors for invasive aspergillosis as far as the external and host factors are concerned. But these risk factors are usually not found in a typical ICU patient. But we see invasive aspergillosis incidences in ICU patients where the host does not fulfill any of these criteria, like they will not be having neutropenia, they will not be having any hematological malignancy, they are not recipient of any solid organ transplant like liver, kidney. So why do these people develop? And there are other factors also, like steroid abuse is one factor, of course, is there. Then patients on chronic kidney disease, hemodialysis, these are also factors which may contribute. Then people having pre-existing lung diseases, particularly COPD, post-tubercular lung fibrosis, and cystic fibrosis, to some extent few cases of bronchiectasis. These are the pre-existing structural lung diseases. They also increases the risk of aspergillus colonization and sometimes invasive aspergillus diseases. Even there are cases where because of occupational lung diseases by virtue of being exposed to silica or coal workers pneumoconiosis, these patients also can develop on the long run invasive aspergillosis if for some extent they are exposed to some immunosuppressive therapy or steroid use. So these are some other risk factors. So these are the risk factors which may be more commonly seen in a typical ICU patient, at least in a setup where a transplant or hematological stem cell therapy are not the routine business. Then the buzzword, the mucormycosis, or the so-called black fungus, which we are saying now, but I don't want to name these funguses with any color. Rather, we all should be using their actual medical terminology rather than black, yellow, white, or whatever color we may give it, because sometimes it is confusing for me also which fungus belongs to which color. So like mucormycosis, the well-known risk factors, particularly in Indian setup and Asian setup, is diabetes mellitus, whereas in the Western literature, the transplantations and hematological malignancy and stem cell transplantations and solid organ transplantation, that constitutes the major risk factor for mucormycosis in the Western patient population. Whereas in Asian continents and our India, we see diabetes mellitus is one of the most important risk factors, including diabetic ketoacidosis and steroid therapy. Trauma is another risk factors, chronic kidney disease and hemodialysis. This has been also reported, particularly from India. Cases have been reported in the context of chronic renal disease and hemodialysis patients. So these are the usual risk factors. In addition to this, now we are adding a risk factor of COVID-19, but whether the COVID-19 itself is the risk factor for the mucormycosis, or is it the treatment, the hyperglycemia, the diabetes, those are actually the risk factors. So as per the available literature, we all know that even among the patients with COVID-19, it is the steroid use and the uncontrolled hyperglycemia has been found to be the biggest risk factor for the development of mucormycosis. So the previous slides was about the general risk factors for various invasive fungal diseases, but these are not the three fungus which have been reported only. there are various other forms of fungal diseases which has been reported in COVID-19 patients. But these are the three most common, like the mucormycosis, aspergillosis, and invasive candidiasis. These are the three most commonly reported forms of invasive fungal disease among COVID-19 patients. But other fungus are also reported, like pneumocystis infection has been reported, histoplasmosis has been reported, cryptococcosis has been reported, Fusariosis has been reported. So many of these fungal diseases has been reported, but these are the three most common that form the major bulk of the burden of the invasive fungal disease among COVID-19 patients. So why do people with COVID-19 are prone to develop any invasive fungal diseases? One of the important thing is that this is a respiratory tract infections by a virus, and we know it leads to the denudation of the respiratory mucosa and exposure of that barrier, the protective barrier, and probably that leads to the invasion of the fungal various fungus, leading to invasive fungal diseases, sometimes locally and sometimes in a disseminated manner. Then COVID-19 associated acute respiratory distress syndrome and the consequent mechanical ventilations and prolonged intensive care stay is another important risk factor, and this has already been highlighted in the previous MERS and SARS and influenza related illnesses where the patients has landed up in ICU. They have required this. Steroid therapy, of course, we all know is an important contributor to the invasive fungal disease. Interleukin-6 inhibitor therapy, particularly the tocilizumab, has been associated with increasing incidences of invasive fungal disease. Diabetes mellitus, nevertheless, we all know about this. Steroid-induced hyperglycemia and environmental factors. And these are all contributing to the increased incidence of invasive fungal disease. Steroid-induced hyperglycemia is basically a iatrogenic things which we are creating, and we can control it with judicious use of steroids and appropriate insulin therapy to control the sugar, mostly to maintain at a euglycemic level at least. Diabetes mellitus, the question is some patients may be having pre-existing diabetes before acquiring COVID, and in those patients also we are seeing a increase in the blood sugar level at the time of diagnosis of COVID-19. Particularly, it's getting uncontrolled, and some patients who were never detected to be having diabetes, but they are also newly getting detected to have diabetes, or at least initially hyperglycemia during the initial phases of the disease, particularly probably related to the beta cell damage phenomenon what we noted. So the question comes, why this is more commonly being seen in this second wave? I don't exactly, nobody knows the very clear answer, it seems, but because for that we need a bigger population level studies, whatever it may be. But maybe with the second wave, with this second variant, the different mutations, whether the incidence of diabetes is more compared to the first wave, and that's why people are more prone to acquire invasive fungal diseases. The level of hyperglycemia is more with this second wave. So all these things maybe needs a proper methodological study at population level, so that we can with affirmity say that probably this is the culprit for invasive fungal diseases, rising incidences of invasive fungal diseases amongst COVID-19 patients. The other issue is why there is increased incidence of invasive pulmonary aspergillosis among the COVID-19 patients. The one thing is there is increasing interleukin-10 level after the viral infections because of the Th2 type immune response. And this is followed by some amount of suppressions of the Th1 type response, and that predisposes to invasive aspergillosis. This is one of the postulations, and some of the animal model studies support this theory. The other thing is we all know about the interleukin-6 inhibitor that we are using in COVID-19 in some cases. Interleukin-6 appears to confer some protective immunity against aspergillus infections and invasion. And when we use tocilizumab, probably we are reducing the protective immune response that we may get from that interleukin-6, and thereby predisposing the patients to the development of invasive aspergillosis at least. The reported incidence of invasive pulmonary aspergillosis in various studies varies from 20 to 30%, particularly in the ICU populations. And the most common invasive fungal, invasive aspergillosis is by Aspergillus fumigatus, followed by Aspergillus flavus as the next common organism isolated. And the overall case fatality rate of invasive aspergillosis in COVID-19 is almost 3 out of 2 patients will die. So the question comes, the biggest challenge, the suspicion is probably with this increasing awareness, many of the physicians and clinicians will suspect. There is no questions that people will not suspect. Many of us will suspect that this patient may have invasive fungal disease, but it very becomes difficult to prove it because of the so many issues related to it. Most of the times, this will be some tissue level diagnosis we need, and it becomes very difficult because these patients are unstable. So getting a diagnosis, a tissue may be difficult most of the time. So many cases remains undiagnosed. So whatever percentage or the incidence we are seeing reported in the literature is probably the tip of the iceberg of such diseases what we are seeing. Actually, many cases are remaining undiagnosed, and they are dying ultimately, and we are failing to diagnose the invasive fungal diseases. So lung biopsy, say for the sake of point, that yes, if we do a lung biopsy, it provides the definitive proof of invasive pulmonary aspergillosis or any invasive fungal disease. But the drawback is that it becomes very risky. It's very difficult, and it is hardly practiced, especially in the COVID setup. Patients will be in COVID ICU on ventilator. You need a CT guided biopsy. So all these things become very difficult. But some suggestion is that post-mortemly, if you want to diagnose at least, so you can do post-mortemly CT guided biopsy from the lungs, and at least you can confirm whether the patient had invasive aspergillosis and died because of that. The next question comes is bronchoscopy with lavage. Yes, bronchoscopy can be done. We can see the airways, and we can also see if at all there is aspergillus tracheobronchitis. At least airway diseases we can pick up right away by looking at that. And we can also collect the ball, and we can send that for aspergillus antigen, PCR, and culture. All these things can be done. But again, we know that bronchoscopy is an aerosol generating procedures, and very sparingly this is being practiced in routine practice. Whatever literature we see, mostly those have been done as a part of some studies rather than incorporating bronchoscopy as a routine procedure of detecting invasive fungal diseases early in patients who are under ventilator in COVID-19. So this is one issue. So, but if we get a ball, then that's a good sample. We can at least diagnose some diseases, some cases with COVID-19 and invasive pulmonary aspergillosis. But the drawback is that it's rarely practiced because of the aerosol generation issues and the infection control measures. Non-bronchoscopic lavage can be done like without using any bronchoscope, using the suction catheter, closed suction catheter, putting some saline 10-20 ml, or a lung catheter like a mini ball. Those things can be done because those are also lower respiratory tract samples, and those have been validated for ventilator associated pneumonia, but these have not been validated for COVID associated pulmonary aspergillosis. So that is the problem. So as of now, this non-bronchoscopic sample has not been validated to diagnose invasive pulmonary aspergillosis. So that becomes an issue. Tracheal aspirate, this may be more easy to obtain, particularly when a patient is intubated, but this does not represent really the lower respiratory specimen. And this is also again not validated for diagnosing invasive pulmonary aspergillosis. So this, if you get some fungus in the KOH or culture also, this can represent colonization. Then sputum, again, this is more of a contaminated sample it will be. So this is also again not validated for biomarker testing, at least like galactomannan and PCR testing. So again, it becomes difficult to establish whether it is disease or colonization if we get some fungus in the sputum. Serum, yes, it is highly indicative for invasive pulmonary aspergillosis. We can do the galactomannan, the lateral flow assay, or the PCR test for the aspergillus antigen. This is validated specimen for galactomannan and lateral flow assay serum. And also we can do the 1,3-beta-D-glucan and PCR. These are easy to obtain also serum. So, but the issue is that there is a very low sensitivity of serum galactomannan assay. The sensitivity is only 21% as far as invasive aspergillosis is concerned. So it's a very, very low sensitivity. And the beta-D-glucan is not pathogen specific. If you get beta-D-glucan has a higher sensitivity compared to galactomannan, but you don't know whether it is due to aspergillosis or whether it is due to candidiasis. So again, you have to do galactomannan and you have to get a culture or a biopsy evidence of the actual fungus, whether it is a candida, whether it is a mucor, whether it is a aspergillus. Of course, for mucormycosis, these biomarkers are not helpful and not recommended. So next, coming to the proposed or the society guideline criteria for diagnosing invasive aspergillosis. These guidelines have been proposed long time back, even before the COVID-19 era. This is pre-COVID-19 usual guideline for diagnosis of invasive aspergillosis as per the European organizations and the mycosis study group. So probable invasive aspergillosis. So for any diagnosis of any invasive aspergillosis, fungal disease for that matter, whether it is aspergillosis or whether it is mucormycosis, we need to have three criteria fulfilled. One is the host factors, that is the patient characteristics. Then the clinical features, the appropriate host has to have some suggestive clinical features that can indicate towards a probable invasive fungal disease or aspergillosis. And we should have at least some evidence of the fungus, that is the mycological evidence. So these three criteria we need to have to diagnose somebody having invasive aspergillosis, either proven or probable. We are discussing here probable because proven doesn't need anything else. Proven is proven. Proven means when we have isolated the organism for a sterile body fluid, like say CSF or the pleural fluid or any other ascitic fluid, any pus, any abscess, or we have done a biopsy from an invasive tissue or organ, and we have detected the fungus, then that is a proven invasive aspergillosis. There is no doubt about that. We may not need a biomarker in those scenarios. But most of the time, this is not possible or feasible, particularly in ICU patients, even in non-COVID patients, and more so in patients who are COVID-19 and under ICU care. It becomes very, very difficult to go for any invasive testing. So we more often rely on the biomarker-based testing for diagnosing invasive aspergillosis, particularly the non-invasive way. So if we see the host criteria, like absolute neutrophil count of less than 500 for more than 10 days, the typical risk factors for invasive aspergillosis. So here we will see that most of our patients of COVID-19 in the ICU will not be fulfilling this criteria. None of the patients will be having this criteria. This is the typical host criteria will not be fulfilled by COVID-19 patients because none of them will be having a, or at least majority of them will not be having any neutropenia or organ transplant recipient. Maybe the steroid sometimes may be useful, but that too not for more than 3 weeks. But though we see some patients are getting steroid even longer than 3 weeks, but this may be the only factor, which may be one factor, host factor, which may be present in the COVID-19 patient. Then the clinical features like CT, again another major challenge is having a CT done. Once the patient lands up into the ICU and in the ventilator, they will be requiring high PEEP because of the bad ARDS. There will be very difficult in ventilations. So to get these patients into CT room and getting the CT scan done is a Herculean task. So many of the times we are unable to get the CT scan done, and our diagnosis is mostly relying on pure suspicion, or sometimes if we are fortunate, the chest X-ray is revealing any nodules or cavitations that only suggest towards invasive fungal diseases. So, but CT is the recommended modality to suspect probable invasive aspergillosis, like dense, well-circumscribed lesions with or without a halo sign or air crescent sign, cavity or wedge septate or segmental lobar consolidation has to be there to diagnose invasive pulmonary aspergillosis. To diagnose invasive tracheobronchitis, we need to have one of the following, like tracheobronchial ulcerations, nodules, pseudomembrane, plaques, or scars seen on bronchoscopy. Mycologically, either the culture should be positive or the fungal element should be seen, at least some molds, evidence of some molds should be seen in the microscopy, or we should be able to detect the galactomannan more than one, either in the serum, plasma, or BAL specimen, or a single serum plasma galactomannan more than this should be 0.7. This is wrongly written as 7 here. This should be 0.7, and BAL galactomannan of more than 0.8. Similarly, the CSF galactomannan should be more than 1, a single CSF galactomannan. So any of these things will confirm that in an appropriate host with an appropriate radiology that yes, we are dealing with invasive aspergillosis probable. Similarly, for aspergillus PCR should be positive in any of these specimens. Then here one more thing I would like to highlight here, that absence of host factors and radiological factors prevents its use for classification of patients with influenza associated pulmonary aspergillosis and COVID associated pulmonary aspergillosis. That what we discussed, that we don't get the typical host, especially in COVID scenario. Then because the ICU patients are not the typical patients of invasive aspergillosis, they are not the typical host. Sometimes back, and as ICU criteria was proposed to diagnose invasive aspergillosis in ICU patients early. This is about putative. This is about putative invasive aspergillosis in COVID-19 patients. So again, sorry, this is invasive. This is putative invasive aspergillosis criteria among the normal ICU patients, not the COVID-19. So here also we need to have that the patients may be having an absolute neutrophil count less than 500 at the time of admissions to ICU, or they may be having any underlying hematological malignancy, or they may be being treated with some cytotoxic drugs, steroid use more than 20 milligram per day, or they have some inborn or acquired immunodeficiency. So this is the typical host criteria that need to be fulfilled by an ICU patient to think of aspergillosis, invasive aspergillosis. Then in an appropriate host, when we will be suspicious of invasive aspergillosis, when there is a refractory fever, at least 3 days of appropriate antibiotic therapy, but the patient is not responding, or the fever had subsided, but again the fever has recurred after 48 hours while the patient is still on antibiotic. The patient complains of pleuritic chest pain, pleuritic rub suggesting some amount of pleurisy. Patient is complaining of dyspnea, hemoptysis, worsening respiratory insufficiency despite appropriate antibiotic therapy and ventilatory support, and abnormal medical imaging by portable chest X-ray or CT scan of the lungs. So these are the clinical features that leads to suspicion of aspergillosis, which will subsequently lead us to do the testing. So we can do aspergillus culture from lower respiratory tract specimens. That is the entry criterion. So either we need to have a non-bronchoscopic or bronchoscopic lavage, but particularly this is for bronchoscopic lavage, and semi-quantitative aspergillus positive culture of bronchoalveolar lavage fluid without bacterial growth, together with a positive cytological smear showing branching hyphae. So we need to document evidence of these molds in the bronchoalveolar lavage fluid. Suppose in the absence of more than one criteria, then the patient is classified as having aspergillus colonizations. Suppose the host criteria is not fulfilling, there is no typical clinical features which can suggest towards an invasive aspergillosis, then probably we are isolating some aspergillus like organism in the microscopy, but that we will consider as Aspergillus colonizations and not as invasive Aspergillus disease which warrants any therapy. After this ASP ICU criteria has been modified. In this original ASP ICU criteria, the galactomannan was not included as a marker for diagnosis. Now galactomannan has been included in this thing, and even in the absence of the host criteria, if the galactomannan is positive, then we can consider the patient to have a putative invasive aspergillosis. Then the expert case definitions for influenza-associated pulmonary aspergillosis. Influenza is also has been found to be a risk factor, and increasing incidences of aspergillosis has been found among the patients with influenza. So again, here the host factor is there is influenza-like illness, that is the entry criterion, and you have a positive influenza PCR or antigen. Then clinical features wise, there is airway plaque, pseudomembrane or ulcer on bronchoscopy. There is pulmonary infiltrates on the CT scan, or there is cavitating infiltrates in the CT scan, which is not attributable to any other cause. And again, the mycological evidence. For tracheobronchitis, we need at least one of the following. If the serum galactomannan is more than 0.5, we have tracheobronchitis in the bronchoscopy, we have an appropriate host who has PCR confirmed influenza, and if the serum galactomannan index is more than 0.5, then we are dealing with a probable case of invasive influenza-associated pulmonary aspergillosis, or a bowel fluid index of more than 1, or the mycological evidence in the culture or microscopy. If we are able to see, then this is a confirmed case of Aspergillus tracheobronchitis. Similarly, for pulmonary infiltrates, we need the same criteria, like the galactomannan index should be more than 0.5, or the PCR or the BAL should be positive for the fungus. And in the cavitary form also, more or less, we have the similar criteria which should be fulfilling to diagnose invasive pulmonary aspergillosis. Then the proposed, these are the previous three slides which are already existing before the COVID-19. Based on these three recommendations by different society, that is the recommendation for the invasive aspergillosis, then the ASP ICU criteria, and the influenza-associated pulmonary aspergillosis. Based on these three recommendations, the current recommendation has been proposed for the possible case definitions for COVID-19 associated pulmonary aspergillosis, or the kappa. So here this can be classified into 4 categories, like proven, probable, and possible. 3 categories: proven, probable, and possible. This possible criteria is only applicable for COVID-19 associated pulmonary aspergillosis, whereas this possible form is no more applicable to aspergillosis in the context of a non-COVID scenario or non-COVID patient. In the non-COVID, either it is proven, probable, or putative. So in the context of a COVID-19 associated pulmonary aspergillosis, we can have the tracheobronchitis or other form which is proven. So here, patients with COVID-19 needing intensive care and a temporal relationship, that is the entry criteria for the host. This is the host factors. Clinical features, here we need to have histopathological or direct microscopic detection of fungal hyphae showing invasive growth with associated tissue damage, or aspergillus recovered by culture or microscopy, or histology or PCR obtained by a sterile aspiration or biopsy from a pulmonary site showing an infectious disease process. Basically, we need to have isolation of the fungus from a sterile site or by biopsy proven. So that is the proven criteria for Aspergillus tracheobronchitis COVID associated. Similarly, for tracheobronchitis probable, here patients with COVID-19 requiring ICU criteria, the host criteria remains same for all the 4 categories here. On bronchoscopy, we see there is tracheobronchial ulcerations, nodule, pseudomembrane, and we do not have direct culture or biopsy proven evidence, but we have the BAL microscopy or the mold and culture is positive, or there is a PCR positive or serum galactomannan positive, or the lateral flow assay is positive more than 0.5, or the BAL galactomannan or the BAL lateral flow assay is more than 0.1, more than 1. Then this is considered to be a probable tracheobronchitis. Then the other forms, that is the pulmonary forms like pulmonary infiltrates or pulmonary cavity in the CT scan has to be there. And again, the same criteria has to be fulfilled as far as the mycological evidence is concerned. We need to have at least one of the following, either the Ball microscopy or the culture is positive, or the galactomenon or lateral flow is more than 0.5 in the serum or more than 1 in the Ball fluid. Or if we are doing a PCR test, then a single positive PCR of Ball fluid less than 36 cycles is indicative of invasive pulmonary aspergillosis, or a single positive aspergillus PCR in the plasma, serum or whole blood, and a single positive Ball fluid of any threshold. It may be more than 36 or less than 36. So it's a combination of serum, plasma PCR and the Ball fluid PCR. If both are positive, then yes. Or if a single Ball fluid PCR positive, then it has to be less than 36 cycles. Or 2 or more positive aspergillus PCR in the plasma, serum or whole blood. So in this context, we will be diagnosing as probable pulmonary aspergillosis COVID associated. Then the another form which has been compassionately included here, so that at least the patients will get the benefit of treatment, that is the possible form. Because here in particularly in the context of COVID-19, it's very difficult to do all these tests as per the recommended number of times. So they have included a possible form, because even with the trivial or little bit of suspicion, the benefits should go to the patient. That is the whole idea of including this possible. So this possible category is only for clinical management, but not for any study or any research. If we want to do any research, then the inclusion criteria has to be either probable or proven. Possible will not be considered into any research study. So in the possible form, again the same COVID-19 patient requiring ICU care has a pulmonary infiltrates, but in the mycological evidence, we have microscopy or culture positive in non-bronchoscopic lavage. Means here you have not been able to do bronchoscopy, which is very appropriate and apt in the context of COVID-19. Most of our patients across the globe, not only in India or Odisha, globally, people will not be able to do as a routine clinical service bronchoscopy. They may not be doing routinely to detect invasive aspergillosis. So if we are able to have some non-bronchoscopic lavage, then the galactomenon index has to be more than 4.5 and not more than 1. Non-bronchoscopic lavage galactomenon index more than 1.2. If a single lavage, it should be more than 4.5, single non-bronchoscopic lavage. Or a non-bronchoscopic lavage galactomenon index more than 1.2, 2 times or more, means twice we should, at least twice we have done the lavage and the index is more than 1.2. Or non-bronchoscopic lavage more than 1.2 at least once, and non-bronchoscopic lavage mycology, PCR or lateral flow assay is positive for aspergillus. So at least we can say that this is a possible pulmonary COVID-19 associated invasive aspergillosis, and we can start at least antifungal therapy with this, at least with this possible category. So this is mainly for clinical point of view. So this is all about how to diagnose, because what is most important is to know how to diagnose these cases before we think of treating, particularly in the context of COVID-19. This was a study they did systematically to screening, whether they thought whether routine screening of the patients who are intubated will help in early detection of these patients. And they included 63 patients and they screened routinely twice tracheal aspirate, and they sent for PCR and culture, and Ball performed in those with positive screening. And what they found is tracheal aspirate was positive in 15, and probable COVID associated pulmonary aspergillosis was diagnosed in 11 patients, that is 17% of the patients. So what they are saying that positive culture, molecular detection and antigen detection of aspergillus species do not equal infection. So we may have mycological evidence in our different sampling and testing techniques, but this is not equal to invasive fungal disease. Until we understand the clinical relevance of aspergillus species detected in the respiratory samples of COVID-19 patients, minimal invasive screening by tracheal aspirate is a feasible method to monitor patients. Positive screening results should be an indication to perform a Ball to rule out upper airway colonization. The question is here that the tracheal aspirate was positive in 15, and however, in only 11 out of 63, the COVID-associated pulmonary aspergillosis was diagnosed. So many times, if we do the tracheal aspirate for isolation of the fungus by molecular methods or culture, then many times it may represent colonizations. That is what we need to understand from this study. Then the study from the CDC, they have found in a large number of patients, 186 patients, where majority were male. Across the globe, in most of the series, the most commonly affected people are the male. Almost more than 70% people are the males affected in all series of invasive fungal diseases. And the median time from COVID-19 diagnosis to the COVID-associated pulmonary aspergillosis was 10 days here, and the range varies from 5 to 16 days. And most of the people, they stay in the ICU at least for more than 7 days. And corticosteroid use was found in 52.7% of the patients in this large series. And overall mortality, if we see the underlying lung diseases and other chronic diseases, many of these patients who developed COVID-19 associated pulmonary aspergillosis, they had many other comorbidities which are most commonly present in many of the patients, like renal failure, chronic lung disease, heart disease, malignancy, and all those things. Neutropenia, however, was very uncommon. We can see that is 1.1% only. And this hematological malignancy and organ transplant is also very few. The majority issues are the chronic cardiovascular disease, renal failure, diabetes mellitus. Again, this re-emphasizes the fact that the COVID-19 patient who develops invasive aspergillosis are not the typical host where invasive aspergillosis has been previously described. That is the hematological malignancy patients and the transplant recipients. Those are not the typical host. That's why the suspicion has to be very different. The approach has to be very different, and it has to be very rational to identify the patients who are actually having COVID-19 associated pulmonary aspergillosis. The overall mortality, if we see, was 52% in this study, and most of them died within less than 6 weeks, and 50% of the patients died within less than 12 weeks. And the cause of death also we can see here due to COVID-19 associated pulmonary aspergillosis. Then the next bigger things which we all are talking now about the black fungus is the mucormycosis. This is a proposed approach to a suspected or a confirmed mucormycosis. Mucormycosis can have various manifestations depending upon the organs it is affecting, and the host may be different variety. And there has been a epidemiological difference globally in terms of the host, because as I discussed in my previous slides, that in Western countries, the hematopoietic stem cell transplant and the solid organ transplant recipients and neutropenic patients have been the most common host for mucormycosis, whereas the diabetes, the kidney diseases are particularly notorious in Asian countries and in China. So we need to think whether what type of host we are dealing with, whether it is a neutropenic or organ transplant recipient or a diabetic patient. So this will be the symptoms, or a trauma patient who is complaining of persistent fever or respiratory symptoms, or a trauma patient who has an eschar. Then in the Asia Pacific, especially China and India, many patients do not have any underlying disease. They simply complain of flank pain, fever. This is particularly the renal mucormycosis, hematuria with sterile urine and blood cultures. Then Asia, specifically to India, we have a different presentations phenotype, like particularly the diabetes, adult patients with diabetic ketoacidosis, people on dialysis, malnourished, premature child with broad spectrum antibiotic therapy with abdominal mass, distension, bilious vomiting, with or without gastrointestinal bleeding. This is the typical host which has been more commonly described in India. This is the typical host which has been more commonly described in Asia and China, like the renal diseases. So if we have this particular host, the next approach should be to get a CT scan done. We should do a chest CT scan and see the typical finding of effusion or reverse halo sign or nodules. If it is a diabetic and we have symptoms of rhinoorbital cerebral, then we should do the cranial CT scan, and if we have suspicion of cranial CT scan of mucormycosis, then we should go for the cranial MRI, or many a times many physicians straight go for MRI of the cranium to look for the rhino-orbitocerebral mucormycosis. If it is a trauma patient, then appropriate investigations of the affected area should be done wherever there is a trauma or the scar or the ulcer is present. Accordingly, we should do the investigations. Particularly if the patients are having abdominal symptoms, then we should do the abdominal ultrasound or abdominal CT scans. We should be doing in this group of patients. Then once we have confirmed the we have confirmed the things, then we should go for the staging. Once there is a suspicion of mucormycosis from these investigations from the CT or the MRI, then we should go for the staging to rule in or rule out whether we are dealing with a disseminated form of mucormycosis. Then we need to establish the diagnosis by biopsy. So we can go for a direct microscopy using fluorescent bright and histopathology special stain, or we should do the culture routine media at 30 degrees centigrade or 37 degrees centigrade, button white or grayish black colony. So these are the things we need to. Then we can go for molecular identifications, that is preferable in semi-nested PCR can be done to look for the particular genetic structures and the mutations to identify the mucormycosis. And galactomannan can be done, but it is not strongly recommended, because galactomannan or 1,3-beta-D-glucan is not done to diagnose, but to diagnose other invasive fungal disease like aspergillus or candida. So this can rule out one thing. The second is to diagnose invasive aspergillosis or candidiasis along with mucormycosis. So co-fungal infections is also possible. So this is all we know about various forms of rhino-orbitocerebral and cutaneous manifestations. The most common form of invasive mucormycosis among the COVID-19 patients has been the rhino-orbitocerebral form. And the next most common form is the pulmonary mucormycosis. So these are the various manifestations. This is in a limb ischemia and the ulcers we can see. This is in a ocular manifestations. Here we can see the pan ophthalmitis sort of pictures. Here we can see the palatal scar and the crustaceans black crust. This is in a neonatal patient. This is in an adult patient involving the facial structures. So these are the myriad of manifestations of rhino-orbitocerebral mucormycosis, which we all are aware of now, and many such cases we all have seen in our practice, particularly our ENT and ophthalmology colleagues. As far as my specialty is concerned, the pulmonary mucormycosis, we can have various manifestations. Most notably, we will see some nodules, or we can see some central area of ground glassing with a surrounding dense consolidation, which are typically described as the reversed halo sign, which we are seeing in the panel B here, the B photograph. In the panel C, what we are seeing here, the photograph labeled as C, is the vascular invasion. We can see here in the contrast study, we can directly see there is loss of contrast in the vessel down here where the arrow is pointing, suggesting towards a vascular invasion by the fungus. Again, here we see a reversed halo sign in the panel D. In the panel E, we see in the MRI picture showing a cavitations close to the chest wall. And these are, of course, the evolving reverse halo sign from G to E to F. So, this is, of course, another thing, a disseminated form we see in the last picture where we see the spine in a coronal image along with invasion into the spleen we can see along with the diaphragm. So here the pleura, lungs, the diaphragm and the spleen has been invaded here in a contiguous fashion. So these are the various manifestations we can encounter in case of a pulmonary mucormycosis, and the final diagnosis will be either from the culture or from histopathology. Histopathology will be very rapid, and at least we can get a clue to the diagnosis in at least 2 to 3 days. So this will be very, very helpful initially. So we can see basically broad aseptate hyphae in the mucor, which are ribbon-like, and sometimes they will be folded or unfolded form, and they are broader compared to the aspergillus, which are septate, and they are thinner and they have branching. But branching is sometimes not seen typically, because once the tissue is processed and all, histopathologically, though morphologically the fungus may be described as branching at acute angles, but many a times the typical branching pattern may not be very obvious in a histopathological slide. But at least the broad hyphae and aseptate, and here the thin hyphae and septa, should be able to help us to differentiate mucor from aspergillus. Then in the Indian context, there has been 2 large studies which have been published very recently. These are the 2 things I can discuss, and then we will close. You all might have gone through, we all are getting this study now being circulated in our various WhatsApp groups, that this is one of the largest study, including 2826, almost near 3,000 patients they have included, particularly looking for rhino-orbitocerebral mucormycosis. Majority of the patients were from Gujarat and Maharashtra, as already told during the introduction in today's session, okay, by the state authority. And the mean age of these patients was around 51 years, sorry. 57% of the patients needed oxygen therapy, and 87% of the patients were treated with steroids. At least 21% were treated with more than 10 days. So we know that oxygen therapy, steroids, and diabetes have been found to be the most important risk factors for this rhino-orbitocerebral mucormycosis among this largest study published just recently from India. This was another study published sometimes back, again across India in a multicentric study. In a retrospective manner, this data has been analyzed. Among 287 mucormycosis patients, 187 had COVID-associated mucormycosis, that is 65.2%. And here they have compared the incidence of mucormycosis in the 2019, that is before COVID-19 and during COVID-19. So what they found, that the overall prevalence of COVID-associated mucormycosis was 0.27% in hospitalized COVID patient. And there has been a 2.1-fold rise in mucormycosis during the COVID-19 period compared to the pre-COVID era, as far as mucormycosis incidence is concerned. Uncontrolled diabetes and was the most common underlying risk factor, but that was again same for the pre-COVID and the post-COVID or during the COVID-associated mucormycosis. So whether it is COVID-associated mucormycosis or non-COVID associated mucormycosis, diabetes was the most important risk factor for both the groups. And COVID-19 was the only underlying lung disease or only underlying disease in 32.6% of the COVID-associated mucormycosis patients, and there were no other risk factors. And hypoxemia and improper glucocorticoid use was the most important risk factors for COVID-19 associated mucormycosis, and the case fatality rate was 45.7%. So nearly 46% patient will die with COVID-19 associated mucormycosis. And last but not the least is the therapy. As far as mucormycosis is concerned, surgery and the medical management should go simultaneously. And the most preferred drug will be the liposomal amphotericin B. And if we do not have liposomal amphotericin B, then only we should consider conventional amphotericins. That is the most preferred drug. And the next preferred will be, if we do not have liposomal amphotericins, then we can also, the next preferred drug should be the IV isavuconazole or IV posaconazole. I think it is not being shown here in the slides. Somehow it has been missing. So after the liposomal amphotericin B, if we have a facility to have isavuconazole or posaconazole, the IV, that should be the next choice. Oral posaconazole should be the third preference, and the last preference should be conventional amphotericin because of the associated nephrotoxicity. And various dosage, we all know that liposomal amphotericin should be used with 5 to 10 milligram. Isavuconazole should be used with 200 milligram TDS on day 1, followed by 200 milligram day 1 and day 2, followed by 200 milligram OD from day 3. Posaconazole is 300 milligram BD on day 1, then followed by 300 milligram OD from day 2 onwards. And oral suspension of posaconazole 4 times a day, 200 milligram. Conventional amphotericin 1 to 1.5 milligram. So usually, initially, we will give an induction therapy of at least 2 to 4 weeks, followed by these drugs should be continued for minimum of 6-month duration. So to conclude my talk, invasive fungal disease are common among COVID-19 patients. Risk of invasive fungal diseases is more among critically ill COVID-19 patients. Then ARDS, mechanical ventilation, diabetes mellitus, and steroid use are risk factors for invasive fungal disease. There has been a very high mortality among COVID-19 patients suffering from invasive fungal diseases, and judicious use of corticosteroids and strict glycemic control are the need of the hour in order to prevent COVID-19 associated invasive fungal disease and the consequent mortality. Thank you, all of you, for your patience hearing. Now we are open to questions.
Thank you, Dr. Manoj. It was an extensive presentation on fungal infections. I was enjoying the slides, so informative and so elaborate. And Dr. Manoj has touched every part, the starting from the incidence of the invasive fungal infections at different scenarios to the present mucormycosis challenge, and also their incidence, their intervention, their management. So now I'll invite our faculties and the panelists for the feedback. Our audience, though not very high, were enjoying the presentations, and I don't think there are much questions in the question box because the presentation was lucid and was in depth, not a very common topic to expect hundreds of questions, but we'll take the summary opinion of our panelist at the end. I congratulate Manoj for such a informative and nice presentation. And to start with, I'll ask Professor Jyoti Patnaik, our Professor of Pulmonary Medicine at SCV Medical College, who is here. Ma'am, please unmute and tell your opinion on this context of invasive fungal infections in COVID-19 and Dr. Manoj's presentation.
Thank you, Dr. Bhatt. Am I audible?
Yeah, you are audible, ma'am.
Okay. Thank you, Dr. Jayant Panda, for inviting me. At the outset, I must congratulate Dr. Manoj Panigrahi for that elaborate and extensive presentation of quite a difficult topic. And as you mentioned, not a usual topic. We all know that humans are exposed to spores of fungi on a daily basis, but most of them are ubiquitous. So it's the intact immune system that is preventing the establishment of these fungal infections. And with the COVID raging through the world over, it has brought out that whenever there is an immune depression, that these fungal infections are established. That it was always there, but because of the numerous cases that came up because of COVID, it was brought out. And more so, the black eschar and those horrifying pictures you see, which also Dr. Manoj showed you in his slides, that eschar that you see with the mucormycosis, it took the headlines, took the attention of the entire world, and most of the public were really frightened of those pictures when they saw it. So that was the main reason for which the fungal disease is now being discussed extensively everywhere, in every forum. We are seeing that the fungal diseases are being discussed extensively. And moreover, the treatment, the diagnostics, the treatments, everything is quite difficult in such a situation, as Dr. Manoj has pointed out. When they are in the ICU, the collection of specimens, getting invasion, getting the CT scan done. All these things, they are real big challenges for everybody. So that has been very well described by Dr. Panigrahi. And treatment also is a difficult option for one reason, that is not available, freely available. The drugs are not freely available. And the cost of the drugs is also prohibitive cost of the newer drugs. And even the echinocandins, they are also only, some of the echinocandins are effective in mucormycosis, which is also again newer ones, because those are having all the prohibitive costs. So these are the reasons that really has been very well brought out by Dr. Panigrahi. Thank you, Dr. Panigrahi, once again for that excellent presentation.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Rightly, you have given the opinion. Then we'll listen from Dr. Shubhabrata Parida, our HOD ophthalmology. She is a panelist for the day, and I think ma'am is connected. Dr. Parida.
Yeah, thank you, Dr. Jayant, to invite me over here. Thank you, Dr. Manoj. You have elaborated very nicely about and touched all the parts of the fungal medicine, including rhino, orbital, cerebral, and also disseminated variety, cutaneous, and lungs, everything.
Thank you.
You have covered everything. I just to know, like, I need to clear my doubts. Hello?
Yeah. You're audible.
Yeah, I just don't need to clear my doubts that when you are seeing in your institute, what is the thing we actually follow? Like if you are seeing a rhino orbital, particularly mucormycosis, then clinically when you diagnose, then immediately we go for a CT scan, MRI, or just a microbiological workup. It's the first investigation for the patient. When we clinically suspect it is a case of rhino orbital.
Right. So if the patient is admitted under our custody, then we definitely will seek the help of our colleague, ENT and ophtha colleague initially. Then they will usually suggest the approach. So mostly the approach is suggested is a CT scan. If a patient has a suggestive symptoms in terms of any facial pain, headache, rhinorrhea or rhinosinusitis symptoms or any ocular manifestations, then usually they are suggesting a CT scan and followed by MRI. And after that, if the MRI is suggestive of any sinusitis or the CT scan is suggestive of any obvious sinusitis, then they are going for the biopsy to establish the diagnosis. Once the diagnosis is established, accordingly they are planning the treatment. So now in our institute, now majority of the cases are rhino-orbitocerebral. Pulmonary form, we have seen maybe some of the patients with rhino-orbitocerebral may be having pulmonary, but we are not very much exposed to those group of patients. There are around 3 patients where we have encountered pure pulmonary form without any rhino-orbitocerebral manifestations.
Exactly. In SCB also, in our institute also, we are seeing majority rhino-orbital and cerebral. Also with skin, like on the face only, the stars. And pulmonary part, actually, Dr. Jyoti Madam can say how many she has seen by now, but most of the cases are rhino-orbitocerebral. Another thing is, after establishing the diagnosis only, you are starting amphotericin B, or on clinical suspicion you are starting?
If there is a strong clinical suspicion, we are starting it even before establishing the diagnosis. Like the patient has typical signs and symptoms, particularly for rhino-orbitocerebral, or if the patient has a typical reversed halo sign in the CT scan or nodule or effusion or a thick walled cavitation, then without waiting for the diagnosis, we are starting amphotericin.
Exactly. That is the point I just needed to confirm and establish that clinically also we can start amphotericin B to save the life and save the progression also. Thank you so much.
Thank you,
Jayan.
Thank you, ma'am. We have a few questions in the chat box, but before that, I would like to take the opinion of our other panelists. Any panelist from AIMS want to put any comment? Okay, Prashant.
Yes, thank you, Dr. Jan, and thank you, Dr. Manoj. It's a nice presentation. It is a comprehensive presentation, I can say. So I think not much to discuss. We can have some queries has to be clear, and that is I think he has already covered.
Okay. Thank you, Prashant. Before we go to questions, I'll request Dr. Niranjan Mishra, who is here connected. I'm on mute, sir. Yeah. Sir, you can unmute, sir. Dr. Mishra, yeah. Sir, you.
Thanks, Dr. Panda. I will just highlight certain findings we have seen in cases what we have registered. Out of the registered 27 cases, below 18 years, there is no patient. Between age of 18 and 45, there are 49 patients. Between the age of 45 to 60, there are 57 patients. And more than 60 years are 21 patients. Out of them, 121 out of 128 are rhinocerebral. Pulmonary only 4, no cutaneous, no gastrointestinal, no disseminated, uncommon presentation 2. Regarding COVID-associated mucor, 102 patients have history of mostly post-COVID. They are mostly post-COVID, not related to COVID, around 25. Steroid therapy associated history is there in about 68 of these. No history of steroid use in 59. Regarding oxygen support, about 58 of these had received oxygen. 69 no history of oxygen use. Male about 103, female about 24, and diabetes is associated in about 105 cases, immunosuppressants in 17 cases, and comorbidity in 21 cases. This is a little bit we have detected in cases that has been registered, and it is I think almost in par with that Dr. Manoj has presented regarding the studies from Gujarat and Maharashtra. But still, I put this question to the elite panel: why in the second wave? Why it was not there in the first wave?
Yeah, actually, thank you, sir, for sharing the data of Odisha. This is not a district or not a particular region. It's a whole of state that you are monitoring, and then this is very important data which shows that Odisha also the percentage and the involvement of the different types are not uncommon. And your question is very valid that after the first wave we didn't get, and why after the second wave. I think Dr. Manoj can highlight about this. Any panel want to put also can tell. This is an important thing.
Yes.
We had first wave, and for some time we were off peak, and suddenly the second wave came. And after second wave, when the second wave has not touched the waistline, we are facing these issues. Manoj, your comment.
During my presentations also, in one of the slide I touched upon this thing that why we are seeing more such cases here in the second wave. Probably there is no foolproof answer to this, but as I said, maybe the virus is of a different mutations, and there is more incidences of hyperglycemia and diabetes. That is one factor maybe. Probably there is overuse and misuse of steroids in the second wave. Number 3, the number of cases are exponentially high in the second wave, and that may be a reason why we are detecting little bit more number of cases. And number 4 could be increased awareness to diagnose and detect such cases.
Yeah.
So because if we see this probably these presentations, this paper from the ophthalmology group, they have presented even from the first wave also. It's not that people were not seeing these mucormycosis in the first wave. They had seen this, but this has not came to the limelight.
Yeah. To my knowledge also,
Because
we had cases after first wave, not in this volume, but we have cases reported also, published also after the first wave. The number is much higher here, and the fear is much higher after the second wave, and the presentation is also life-threatening in an advanced stage. Dr. Parida.
The
Yeah, I
incidence is
just wanted
genuinely
to.
more. There is no doubt about that. The incidence is of mucormycosis is genuinely more compared to the non-COVID era. So definitely the COVID itself or the associated steroid use might be responsible for this. We don't know how much is oxygen contributing to the so-called industrial oxygen. We don't know. The other factors which I highlighted in the slide, but probably I did not elaborate it, is that environmental factors is one factor. Means what does it suggest? That now, because of the exponential rise in the COVID cases, we have opened up many temporary hospitals for COVID hospitals in area which was not previously built for hospitals. So this temporary area where we have done, maybe that those areas are not very suitable for the contamination point of view, from the fungus point of view. Those are not as clean and as hygienic as an hospital should be. So these are also factors. That is the environmental factors, because globally, it is not only in India, globally hospitals have been opened particularly for COVID-19 in a short span of time at different locations.
Yeah,
So maybe those locations and that area is not designed to be an hospital in that fashion, and the hygiene may be contributing also to the increased rising incidences of COVID-19. I mean, associated mucormycosis.
Yeah, because it's a ubiquitous fungus. It's a saprophyte, and mostly in the soil. And this massive hospitals that we are doing,
Yes.
they are the responsible. So that's a valid point. Dr. Parida, I wanted to say something.
I want to add also
Yes.
two causes. This one possible that there is, I think, in addition to Dr. Manoj has highlighted, the initial phases we don't have so much of use of steroids. Steroid was initially not used, and later on steroids were used. And second phase, not only the virus is more aggressive, but the disease is more severe. But in addition, what has happened? Steroid has been mostly started on day one. It is left, right, center, and very high doses. Steroid has been used as thinking that we have only drug steroid, nothing can save other than steroid. That is one use. And steroid has increased the diabetes, increase of blood sugar, that is proper. And the other issues and that we have promoted as immunobooster. Zinc is one of the component of immunobooster. That zinc, we should think zinc is a nutrition for the fungus, but we forget that that zinc may be helpful for immunity or other thing, but it has given nutrition and growth for the that aspects of all the fungus, including mucormycosis. So possibly overuse of zinc, that is one of the factor. The second factor, Dr. Manu, so that also there is another thing. There is report, and I have seen the seasonal variation. The seasonal last where was it? It's somewhere in July, August, September, October. These are the time and humid climate is there. There much of this, this is ubiquitous and it spreads more in air. So the timing of this phase, the second it was in April and May, where the most of the India's is a dry climate, and this one spreads on the air. So possibly the seasonal causes, that means dry climate, that has propagated this infection. The otherwise, these are all possible reasons. This for the literature I have searched. I think there's some panelists can add other reasons also.
Very right, Prashant. Rightly you summarized that oxygen is an issue, NAC shift is an issue, climate is an issue, zinc is an issue. So beyond steroid and beyond diabetic control, we have so many factors contributing. Dr. Parida,
masks also.
yeah, ma'am. Unhealthy masks. Yeah, unhealthy masks.
Unhealthy masks.
Yeah.
Repeatedly
Most of,
used without.
ma'am, most of the people were using cotton mask. They are reused without cleaning, and very unhygienic, unhealthy weight with the sweat, and we have seen the situation. So, Dr. Parida, I wanted
almost all the points are touched what I wanted to say. Just one thing, sometimes the cases are confusing, like there is no hospital admission being COVID positive. Some people have only 1 day or 2 days history of fever. They are never admitted to the hospital. No history of oxygen or not even steroid. In those cases also, we are seeing this mucormycosis. Probably environmental factor carries much there. And one thing is, even in non-diabetic persons also, we started seeing diabetic very high blood sugar and rise, like acute rise of blood sugar for in a short period in COVID patients. Maybe
Very
that
nice.
is again a factor.
Yeah,
And
first,
vascular thrombosis.
yeah, please tell. Yeah, Dr. Parida.
Yeah, I think that's not only I need to say. Probably more and more follow-up of the cases will give us some conclusion.
Yes, tropism for angioinvasion leading to
Yeah,
a lot of necrosis is also one of the
exactly.
factors in COVID actually. You're right
But
about that.
and histopathology also by the pathologists are not seen in all cases vascular thrombosis. That is also in many cases it is confusing also. So maybe more and more studies of these cases and more follow-up may give us some clue.
I
Final,
think
but definitely the steroid abuse of steroid, diabetes, environment, and unhygienic mask and all these are the major contributory factors.
yeah, I think Professor
But
Nirupama Chaini is here among the panelists, our head of microbiology and chairman of this mucormycosis committee of the state. Ma'am, your opinion, Professor Chaini. Bayantimala ma'am is also there, our head of microbiology AIMS and a panelist from AIMS. Ma'am, your opinion.
Yeah, I think all the points have been very well covered by all the panelists already, all the possible causes of mucormycosis, which I think we have already discussed in one of the previous presentation. I just wanted to add that this virus itself has some diabetogenic, plays some diabetogenic role because it has been shown that this virus affects the beta cell of pancreas and causes hyperglycemia. So
Yeah,
that also contributes.
yeah, it causes ileitis actually. It causes ileitis, and that's why the hyperglycemia in non-diabetics, what Dr. Parida was talking
Yes,
about.
yes, exactly.
So thank you, ma'am. Professor Choini is there.
Yeah,
Yeah.
everything has been covered as per Bajanti told, and he has the speaker. He has told everything very nicely and described it very nicely. So this mucormycosis, you told that it's a ubiquitous fungus. Definitely, it's ubiquitous. Previously, nobody gave importance, and in this COVID-19 pandemic, due to many factors, the virus got an opportunity to cause the disease, and we have to be very careful, as Bajanti told, that itself the virus can increase the blood sugar because it affects the beta cell of pancreas. So all factors, taking all factors into consideration, we should be very careful. However, many studies is to be taken. So we cannot conclude that with a little bit of the research work that this is about that. So we have to carry the studies to finally come into the conclusion. But definitely, these are the factors. So thank you very much.
Thank you, ma'am. Actually, this shows when all the panelists contribute their views, how the topic and discussion becomes complete. Not only Manoj has told an exhaustive list of all fungal infections, invasive, including the risk factor and management, but all have contributed what needed to be added in this presentation. So thanks, panelists. Thanks, Manoj. We have a few questions in the chat box. There are also very relevant questions. The first question was incidence of pediatric age for the mucormycosis. So Dr. Manoj, you will answer this. In children, what is the incidence?
What is the incidence in pediatric age? I have no idea for this.
So,
but it's reported. It's not reported, but as such, this will be mostly in the context of non-COVID, because we see pediatric age group people are not highly affected with COVID, and if at all affected, they are not severe. So the whatever cases reported in the context of COVID is adults usually.
yeah, and you have also
So
shown
in the non-COVID context, yes, there are the other usual risk factors which are well known for pediatrics, particularly even in the pediatric patients who have diabetes or DKA, they will be having this thing. But exact incidence, I really don't know at this moment. If
Yeah.
any pediatrician is there, they can help us.
Yeah, I searched literature in between the questions they asked, but most of the series that they have reported from 12 years to 12 years onwards, and what Dr. Mishra from DHS is informed, they true that our data is from 18 years onwards. So I think that goes with at par with the other data. So pediatric is uncommon. If it is IDDM or some other risk factor there, can be selectively, but not much of pediatric report is there in even if literature, maybe isolated cases, but I don't think there's much literature, and we cannot have any just extrapolate for the incident point of view.
Yeah, true, because the COVID has not been much in the pediatric age group. We are anticipating, we are preparing ourselves. Until now, the number is not high. So beyond COVID, people have started anticipating the mucormycosis in pediatric.
So maybe the right answer to this question will be giving in the next wave.
Maybe we'll review after the third wave what is the scenario, like first, second, and third, what is there in the children. And many congratulations for Manoj have come. Dr. Dhriti Dash has asked, should we continue steroids in suspected cases of mucormycosis, hospitalized COVID-19 patients? Suppose patient was on treatment, immediately we should stop if he has developed, or we should continue?
I think if the suspicion is strong and there are telltale signs, clinical signs and symptoms, or at least some radiological confirmations, then we should stop, because that is something which can propagate the invasion very rapidly and can kill the patient. But the suspicion has to be very, very strong, because many times it becomes very difficult. Like this, if there are sure signs, at least an imaging should suggest, not purely on clinical. Like if it is rhino-orbitocerebral, they may complain of some eye pain, these, that. Unless we have a visible scar, it becomes very difficult to differentiate whether this headache is due to what, whether it is due to virus-induced headache because of the COVID or something like that. So at least some evidence of sinusitis or invasion involvement in the imaging should be established, so that we can stop the steroid early, and imaging can be done at the earliest.
Yeah.
But once we have slightest of evidence in the imaging, we should stop it.
Yeah, I think that's the right approach. And I also want to remind here that the dose of steroid should be as per the recommendation. What we tell, dexamethasone 0.1 and the methylprednisolone 0.5, it should not be more than that. Many centers are using very exuberant dose with the fear of going to the cytokine storm. That may be a cause. And this rational use of steroid in the right dose in the right duration will not require so much of decision regarding whether to give or stop, because it's a very late complications of prolonged steroid therapy. And Dr. Shuman Panigrahi has asked, pediatric nephrotic syndrome on steroid 2 milligram per kg, maybe prednisolone or something, I think he has meant, suffering from COVID-19. The incidence of mucormycosis is high or normal, or other COVID patients, difficult to diagnose in children. So the child is positive, and he's already a patient of nephrotic and on steroid. So there, what to do? He has asked, because he's already on a long-term steroid therapy.
I think the steroid should be continued here, because it's not that everybody who is on steroid for other indications will develop COVID. Not all patients who take steroids develops COVID, but develop mucormycosis. But most patients who develop mucormycosis are on high doses of steroids, or at least longer duration of steroid. But in this context, it is a pediatric patient. This pediatric patient is taking 2 milligram per kg body weight, as per the question it seems. I think he should continue that, because he may not need escalation of steroid, because mostly pediatric age group patients will not develop severe COVID.
True.
So because that is his routine steroid therapy, what he is taking for years together, and he has not developed mucormycosis so far, I think they should continue the same thing.
Yeah, he has to continue. The message is clear. So I think we have covered all the questions. Very nice comments from panelists. Before we conclude, any comment from any panelist from AIMS or from SCB or from IDSP?
Yeah, I just want to say that Odisha is lucky in that sense in compared to Maharashtra and Gujarat, because the disease, the COVID is following from north and west of the India to east and so south of India. So by the time it reaches peak in Odisha, we have been knowing that we have been very much aware of that the mucormycosis in situation in Gujarat, Maharashtra, and other states, the northern states. So we have been much prepared. I mean, the doctors of Odisha has now been aware that the misuse, some sort of knowledge has given that steroid misuse and control of diabetes is more important. I think that awareness has, I think that has decreased the number of cases in compared to other states. I believe that this 100 means people will laugh. That's definitely it is. Definitely, I can say it's congratulations for the team Odisha that have been able to decrease the incidence of the mucormycosis. That I can say.
Thank you, Dr. Prashant. I think we had a very fruitful discussion on a very important topic. Yeah, Manoj.
And to continue the same thing, I will just take the opportunity of this forum to say that in our institutes, whatever our ENT and Ophtha colleagues are treating, the majority of the patients of rhino-orbitocerebral mucormycosis what have been admitted to us now, actually they have been treated elsewhere. Yes. And very few only those who have received treatment in our institutes have developed mucormycosis. The reason being that we have been very judicious, and we are trying to be our best as far as steroids use is concerned. So that is what I want to highlight. Almost 80%, 90% of the patients who are here for treatment with rhino-orbitocerebral have been treated for COVID elsewhere.
True, very true. And it's not only this mucormycosis, but overall invasive fungal infections you have discussed. It's a very clear proposition. So I thank all the panelists from SCB and AIMS who have done a marvelous job. Dr. Patnaik, Dr. Chaini, Dr. Parida, Bajantiwala ma'am, and Prashant. And then the presentation was excellent, Manoj.
Thank you, sir. Thank you.
Yeah, very informative and a lot of appreciation in the chat box. Of course, it's a high-end topic that we have chosen. So the common doctors, it's very difficult to even frame a question, leave aside making it through. But it's very relevant, and I'm sure many more will watch the program in the YouTube. So with this, we'll be concluding. A good information. Our Honorable CM is inaugurating this pediatric COVID capacity building program tomorrow evening. I'll send the link around 5:30 by Oshwan connectivity, and you all are invited to join. So formally, on CM sir will just start the pediatrics training, and already we are doing the training. We have done two very fruitful sessions, and we'll be doing in the future. And second thing, for the next week, I think we are keeping a very important topic of the Delta and Delta Plus variant by Bajantimala ma'am. So I think Prashant will coordinate and tell me the dates and the topics. And we are very well going on program, and a lot of appreciation from different end. So by thank all the panelists, all the speakers who have done very good in this front. And with that, we'll end today's program, and see you next week again. And stay safe, take care. Thank you everyone.
Thank you, Jayan.
Thank you.
Thank you, ma'am. Thank you.
Thank you.